Good morning, I'm going to start. Please. Silent. So I'm doing it in front of everyone so you can see me doing it. Put your phone silent. Good morning. My name is Dr. Hussein Al-Awad. I'll be co-chairing this session with Mr. Manuel. And just before I started that in the morning, I said to Dr. John Dahl, who's the other speaker, that I'll be a good chairman. And he said, why? I said, because I'm a good chairman at home. So I'll try to be a good chairman here also. And he said, yes, that means you at home you do what you're being ordered to do. I said, that's right. So I'm a good chairman at home. I hope to be a good chairman here also. I'm not a professor, although it says here is a professor. Actually, my name is Dr. Hussein. I'm an ICU consultant. And when I was doing my ICU fellowship, I discovered that the bacteria are smarter than me. So I decided to be smarter than them, and decided to do an ID fellowship. And after I did my ID fellowship, I discovered they became more smarter, more resistant. So today our program actually we'll have our first speaker. Put the slides, please. We're starting a little bit late, but I'm also good in timing, so I'll try to control the time. So we can make it, it says here, we should go to the break at 11:10, so probably we'll make it at 11:15. So that means around 55 minutes. That should be fair for two presentations, actually. Can you upload the slides, please? Or I have to move from here. Here we are. Okay, so Professor Manuel Garcia, he will be the chairing, and I will be the session co-chair. He's the director of the Department of Critical Care Hospital at Clinical San Carlos, Associate Professor, Department of Medicine in Madrid, Spain. He's a member of the Spanish Society of Intensive Care and Healthcare Medicine. He's the Madrid Regional Society of Intensive Care Medicine, Spanish Society of Clinical Microbiology and Infectious Disease and of course, well-known speaker, figure, and active person in the ECMID actually. We see him every year in ECMID, and always active in his presentation actually. He's also recently on the board of director of the SEMICU, which you can see up there, it says Spanish Intensive Care, and he's the president of the scientific committee. His research interests include clinical trials in severe sepsis and septic shock, antimicrobial agent, nosocomial and community-acquired infection, and bacterial resistance. That's me, I'll skip that. And I just want to say that before each presentation, each speaker will ask you to vote and evaluate the speaker. You'll see the individual response system on the table. Please respond to that. And we're going to hear actually a success story now, because we always say that bacteria, as I say, they are smarter. Even during I could not eradicate them, I could not control them, but there's always hope, there's always success. So we're going to hear Professor Manuel speak about this success. That's the program actually.
Thank you, Dr. Hussein.
I'll sit there.
It's always a pleasure to come back to UAE, and I've been lucky to come here once per year, and we actually met last year, and I would like to thank the organizers of the meeting for having invited me. So I will be co-chairing with Dr. Hussein this session, and would like to start with one of the biggest problems that we face in intensive care. At least it used to be this problem. As we will see now, some things have changed since then. This is a beautiful abudabi. So this is my hospital down there. It didn't look like that all the time. It's actually a very old hospital which was founded in the 18th century. So that just give you a few data of where I come from. And shortly after moving to its current location in the 1930s, unfortunately, doesn't show up here. In the middle of the slide, you see is Madrid, and shortly after the building was completed, the Spanish Civil War broke out between the Republic and the army under General Franco. You see in blue the uprising army territories, and in red the Republican. And here in the middle, this is Madrid, and right in the middle of the hospital, the Battle of Madrid was fought. And you see that the hospital was completely destroyed. But the battle was fought fiercely inside the hospital. And you see that soldiers had barricades within the hospital and were shooting from one room to the other to conquer the hospital. And so when people see this at some meetings where I show it, they think that this may well be the surgeons shooting at the anesthetists, or the internists shooting the infectious disease people, I don't know. Whatever fight you fight in your hospital, I hope it's not with weapons, but just with words. And you see, this is nothing original. It was invented 80 years ago in Spain to fight in hospitals. We've done some renovation, and it looks a little bit better now, and you're more than welcome to visit if you're around and come to Madrid to see a Real Madrid game, and also to see me, of course. So what I'm going to be talking about is one of the called zero infectious disease or zero tolerance to infectious disease projects in Spain. These are national projects. We started off with zero bacteremia, then did zero pneumonia, which is the topic of my talk now, and then zero resistance, which has just finished a few months ago. And there was an expert committee for each of these projects, and I was lucky to be part of those. So my first question to you, and I think you have the keypads on your tables, is what is the incidence of that in your ICU or the ICU of your hospital if you're not an intensivist? I don't know. It's something I don't deal with. I think it's high because I see frequently patients with this problem, with this complication, but I have no exact figures. We don't have that problem. There is no VAP in my ICU. The VAP incidence is low, below 5 episodes per 1,000 days of mechanical ventilation, or less than 10% of patients, which is roughly similar. And we have a big problem, and I know there is about 15 episodes every 1,000 days of mechanical ventilation. So we can draw from this, conclude from these results that there is a certain problem. About 2/3 of you think that there is a problem and the incidence is high. Now let me give you some data about what we can do about it. In general, there are many types, a long list of measures to prevent that. You see that there are general non-specific infection prevention, like being aware, screening is one of the first things you probably want to do if you have a problem, to quantify the problem. Then there is, of course, hand hygiene, have the adequate staffing levels. It has been related to reduced staffing levels, not only more infectious, but even more mortality. And then single room isolation and cohorting, which is debated. Then there are general antimicrobial, like washing the patients with paraxylene, or doing adequate environmental cleaning, as you see here. And then are there considered more VAP-specific type of prevention, because they impact on the airway colonization and infection, like the non-pharmacological subglottic aspiration and semi-recumbency, we comment on that, and then the direct application of antibiotics. I will focus a little bit more on the VAP specific, because I think this is the group of measures that are more effective in preventing VAP. You have the subglottic aspiration. I will show you a cartoon on that, and then also the elevation of the headrest of the beds. This is controversial because it has never been really reproduced. The first paper by a Spanish author, Antonio Torres, from Barcelona, published in The Lancet, was very, very dramatic reduction. But if you already have secretions which are contaminated in your oropharynx, then elevating the bed rest is not a good idea. So it's probably related more to having an adequate enteral nutrition protocol, avoiding over-distension of the gastric content than anything else. And of course there are other physiological advantages of sitting the patient up. Being awake, looking around, perhaps having a TV set or a watch to see the clock, to see what time it is, which is very important to prevent delirium, but not necessarily to prevent that. So it's convenient, but it's not that specific probably. To avoid change of ventilated tubing, you're not supposed to do this. This was a recommendation by the CDC, but it turned out that manipulating the tubing actually soils the airway with contaminated secretions that came out first and then are brought back in. And of course, aseptic management of the airway. This is subglottic aspiration. There is a meta-analysis showing that it is effective and that it produces mainly early onset pneumonia, early VAP. Probably because you aspirate what has spent only a few hours in the airway, you aspirate it back. And this is the cartoon. You see, these are tubes that have It's not shown on here. These are tubes that have an additional lumen to absorb the blue area on the cartoon, to absorb subglottic aspiration. That is, aspirations that have passed the glottis, the vocal cords, but are above the cuff. Okay? But they're not, this is not effective to prevent late valve. There is no effect on Pseudomonas, MRSA, Klebsiella, and other late episodes of respiratory tract infection. The term selective decontamination of the digestive tract is very well known in Europe and not so much outside Europe, but it consists of a group, of a little bundle of interventions doing the job for early onset infections with a short IV antibiotic course. The classical was 4 days of cefotaxime. We nowadays in my unit use 3 days of ceftriaxone, just 3 doses, to prevent early onset VAP, early onset urinary tract infection and other infections, but mainly respiratory tract. And then we give topical antibiotics to decontaminate the oropharynx, which is where almost all the germs come from that cause lower respiratory tract infection like VAP or trachobronchitis. And then we give through the nasogastric tube the same combination of antibiotics. So here we see the efficacy of the short course of antibiotics, reducing the incidence of both early onset and later onset. Now here we have a problem with definitions. If you say 48 hours is the difference, makes the difference between early and late, you're probably wrong most of the time. Because you may have early onset that is strep pneumonia in a trauma victim on day 3 or 4 or 5. And it would be grouped as late, but it's not really late. It's just that it has developed later, but it's obviously something that hurt the patient already carried in the upper airway. It has just come down. But this prophylaxis is very efficient in reducing, in a trial we did a few years ago, from 50 to 15% the incidence of early onset pneumonia in those patients who are not getting antibiotics anyway. That is, trauma victims, stroke victims, attempted suicide victims, all those who are obtunded, who have a low level of consciousness, benefit from this short course of intravenous antibiotics. And this is a trial also showing, although it's not shown on the table, that the sooner you get in with your ceftriaxone, the more efficient you are. Mostly within 3-4 hours after trauma, for example. So this is the topical prophylaxis. The other part of the selective decontamination regimen is just a little bit of paste every 6 hours. It contains tobramycin, colistin, and amphotericin B. And the same mixture is given in a 10 milliliter, it's not a solution, it's a suspension because amphotericin is not soluble in 10 milliliters, through the nasogastric tube. Now there have been a lot of discussions around this because there were people against it because the regular use, the routine use of antibiotics would favor the appearance of resistance. This has not been proven, it's not the topic of the talk, but it has not been proven to be true. It's actually the other way around. But in terms of lower respiratory tract infection, RTI, it is very protective. It's probably the best thing or the most efficient thing one can do to prevent respiratory tract infection in intubated patients. And it also has a marginal but significant effect on mortality. In this meta-analysis, and I'm showing this one, although it's a little bit old, it's from 2009, because this is an individual patient meta-analysis. So investigators who had published in this area, we were asked to provide the individual patient variables, so that it was not done with the group data from each study, but from that all the patients were united as if it were one only study. So there's a significant reduction in mortality as well. And a more recent meta-analysis published in January 2015 from a French group and emerging an associated editorial, favorable editorial by an American author, showed that out of all the prevention strategies that have been published in different studies, the only one reducing mortality was actually SDD, selective decontamination. Okay? This is the main result. But you have to keep in mind that this effect is only apparent if you use the whole regimen. Some authors have said, oh well, I'm only going to use the base, I'm only going to use the oral, or only the IV antibiotic. It is the combination of the three that makes the difference in terms of mortality. Now, the next step would be, instead of just using one or the other, subglottic aspiration, selective decontamination, elevation of the bed, to bundle several effective measures. And this is an evolution that has been growing over the last 10 years or so. The Americans included it in their Save 100,000 Lives campaign, and I'm going to show you as well the Spanish VAP prevention bundle. So this is part of the initiatives of the Institute for Healthcare Improvement, and one of their main objectives was to prevent ventilator-associated pneumonia by doing this ventilator You will, those of you who work in intensive care will immediately see that only really one could be considered a VAP prevention strategy. The others are perhaps quality improvement measures that you should consider, but daily station location has shown to significantly reduce by 1 to 2 days the duration of mechanical ventilation, which is good, but none of the studies show or give any data about VAP prevention. So we don't know actually. It's just intuitively something you need to do, of course, and we will hear more about this by Dr. Breuer, I'm sure. Deep venous thrombosis prophylaxis, this is something you're supposed to do, of course, but it has never been shown to reduce the incidence of VAP, of course. And some studies have been published by putting this into place, and you see there is a positive effect on the incidence of VAP, which is something you would expect if someone starts looking at it and perhaps washing hands more efficiently or more frequently, then you would reduce the incidence. And actually, this is the results suggest that there is an improvement in hygiene because it is mainly due to the reduction in respiratory infection due to MRSA, to methicillin-resistant Staphylococcus aureus. So there was probably associated with this an improvement in hygiene in this intensive care unit. Now in Spain a few years ago, it was one of our main problems. We had about 15 episodes, so relatively high, per 1,000 days of mechanical ventilation. And out of our surveillance program, which looks at VAP, at urinary tract infection and of different types of bacteremia, it was the most frequent complication acquired, infectious complication acquired in the ICU. This infection surveillance program gathers information of all patients staying more than 24 hours in the ICU from the 1st of April to the 30th of June. And you see that the participation started in 2000, it started actually in 1994 with some 70 units, but it then has not stopped to, afterwards not stopped to increase, and nowadays it's about 200 units which participate every year, with an increasing number of patients in the bar. So the last survey, we don't have the results, they will be presented shortly in March. But in 2015, we have data of about 24,000 patients staying more than 24 hours in our ICUs, and you see 200 units for Spain would be almost all of them. Only a few of the public hospital big ICUs would not participate, and those who do not are in the hands of anesthesiologists or private hospitals, mainly small private hospitals. But you could essentially deduct from this graph that most of the Spanish ICUs do participate and enter their data into a web-based portal. This was the situation, and in 2008, you see, almost 15 episodes, 2008 of mechanical ventilation in VAC, UTI, and bacteremia were above what would be nowadays considered adequate or acceptable. And this is exactly the same figures. 45% of our infections were actually VAC. So let me ask you again a few questions to get an idea of what your situation is. About VAC prevention measures. Are you aware of in your units that there have been VAC specific measures that they have adding, that they are implemented or not? So the first one would be, I'm not aware that there any specific measures have been implemented. We use, but they are the non-pharmacological ones, that is, we elevate the bed rest, and we do also symbiotic aspiration or some other devices. There are a lot of devices now on the market which aim at reduction of that. We use a short systemic antibiotic course. We use the topical component, we give topical antibiotics. Or we have a whole bundle of pharmacological and non-pharmacological measures in place. Please vote. Okay, that's nice. So the situation would be then that there is a bundle in place, but there is still the feeling that that occurs more frequently than you would like to. Okay, next slide, please. So the first project was quite successful. You see that there is a reduction from almost 4 to less than 2 episodes of primary and catheter-related bacteremia in our Spanish ICUs, and this is measured per 1,000 days of intravascular catheter, as you know. And therefore, we copied the structure for zero VAC. We did exactly the same thing. And it consists mainly in involving a lot of institutions and people. And this is the reason and the background of the success. So the GTEI, which is the Working Group for Infectious Disease of our Intensive Care Society, comes up with the idea and starts working on the bundle and proposes then to the Ministry of Health, to the Spanish ICU nurses, which are the ones actually doing what you think of after talking to God or to Allah. You come back to earth, and then who is doing that is actually the nurses. You need also the regional healthcare authorities, because in Spain they have a contract with each hospital, and so we got it on the contract. Less than 9 episodes of VAC, or less than 4 or 3 episodes of bacteremia. So the CEO of the hospital and the medical director will come back to you and ask you for this goal to be achieved. But then you say, well, let's meet because we have some problems. We don't have the adequate resources for that. So this interaction or this communication is then, of course, beneficial for your project. And per hospital, per ICU, there needed to be one physician and one nurse coordinators. So really, if you excuse me, the pain in the ass for the rest of the colleagues. Because
reporting is mandatory, the trough level is a must. And we are talking about a trough level between 15 and 20, and believe me, if the vancomycin MIC for MRSA is 1, probably with a trough level of more than 25 if you want to clear the infection. The second important point is the rising MIC. 20 years ago, I have never seen an isolated MRSA which is having an MIC more than 0.5. Now 1 is the standard. The problem is, this is happening everywhere. And as you can see, it's not our data, this is an international data. And you will see that the red line is going up, and the other lines are going down. So the more sensitive MRSA to vancomycin is going down, and the more resistant MRSA to vancomycin is going up. And with going up MIC, the rate of failure is very high. This is a collection of some studies which is telling to us clearly that if your MIC is high, approaching 1 or above, you will be faced with failure, failure, failure. So it is not an antibiotic issue, it's an organism issue. It is the relationship between the MRSA and the vancomycin. The last one is the heteroresistance. Heteroresistance is something which is related to the inoculum density. Sometimes the vancomycin appear very sensitive in the antibiotic sensitivity report. But once you increase the inoculum density, it appears as if it is resistant. Look at the green lines and the red lines. You give the antibiotic, the concentration of the organism go down, but then it grow up again. And they try to know why. If they increase the density of the inoculum from 10 to the power 5, which is the standard one, to 10 to the power 6 or 7, whatever is sensitive, it appears as if it is resistant. So they tried to do that, and they found that by stepwise exposure to a larger density inoculum, 74% of what looked sensitive appeared heteroresistant. And this is probably will explain to us why, in most of the cases, if we don't know how to use vancomycin, you will be faced with failure. So the guidelines have shown us that if you are suspecting, or if you have an MRSA, HAP or VAP, lidozoline and glycopeptides are to be used, but we do have some problems with vancomycin, which if we don't pay attention to it, you will probably face a lot of failure. And thank you very much for listening.
For handling this tough topic, actually reviewing the guideline, all probably 100 pages in this 30-35 is really tough actually. So thank you very much for stating that. And then we have time actually for questions, please.
Thank you, Mark. Thank you very much for your nice presentation and your information. My question is, two questions related to both speakers, maybe any one of you can answer it. You see, we have in ICU Acinetobacter, and most of the ID consultant is their writing cholesterol aligned with imipinum and meropenem. Though the imipinum and meropenem is resistance, and they are saying to save the soul, the whole soldier. This is number one. Secondly, suppose the pneumonia is secondary to intra-abdominal sepsis, and the patient is already on tetracycline or intra-abdominal sepsis. It can cover if there is pneumonia, there is MRSA growing from the sputum also. Yep. You can add linezolid in addition to that.
Okay. The first question first.
The first one is the use of a carbapenem in apparently carbapenem-resistant isolates, whether it is Acinetobacter or Pseudomonas, in addition to the cholesterol, isn't it? Yeah, it's a trend happening now. I think Professor Garcia will just tell you about that. There is still some tendency in dealing with the carbapenem-resistant organism to keep the carbapenem on board as if it's creating a hole in the cell wall, then the cholesterol will work later on. I really don't believe in it, but the reports in the MDR, they are all case series. And they are insisting that you can still use a high-dose carbapenem plus the cholesterol. I told you that the cholesterol is not a good antibiotic. And if you use it alone, you will be really in trouble. So that is the reason why we are still using another carbapenem, whether it is from the piperacillin tazobactam, or from the cephalosporin, or from the quinolone, in addition to the cholesterol, to treat the MDR, whether it is Acinetobacter or the Pseudomonas. I don't believe in it, I don't have data about it, but people who are in the research work can give you a better answer as well.
If I may make a comment to your question.
You can hear the microphone.
Is it working? Yeah. For carbapenem-resistant antibacterial, there are some data in the literature. I will show you one example in my last presentation, suggesting that you actually need combination therapy to lower your mortality. So So not only is it sometimes the only choice we have, but it seems that nowadays, and although there are no randomized trials, retrospective data analysis suggests that you need to use carbapenem high dose with colistin and with tigecycline to treat carbapenem-resistant microorganisms. No,
So it looks like it's still a logic option in treating a multi-drug resistant, even if it is a carbapenem resistant, despite it goes without saying that if I have a resistant organism to an antibiotic, I have to stop it. This is the logic saying that. But the case here is, as Garcia said, that using a high-dose carbapenem plus the colistin and possibly a tigecycline, of course, if it is not a pseudomonas, because tigecycline doesn't cover a pseudomonas, is a possibility to do that. And I don't want to tell you that there is some Italian group who are working on a double carbapenem at a high dose to treat a carbapenem resistant, provided, of course, the MIC is less than 16.
The outcome was that after using this practice for 1 year, we found a lot of carbapenem resistance in Helicobacter is emerging in our unit.
Yeah, you already started the treatment because of the carbapenem resistance. I cannot say that this is now increasing. You are telling I have a carbapenem resistant, which is either a KPC or a CRE, and this is the reason why you want to put the colistin. But the idea is you want to stop the carbapenem. The case series is telling if you maintain the carbapenem at even a higher dose, like a 2 gram TDS for the meropenem, and use the colistin on top, if it's a pseudomonas, or use the tigecycline as well, if it's an Acinetobacter, you will have a better outcome.
Thank you. One question at the back.
For the issue of tigecycline and pneumonia, tigecycline, it is written in these guidelines, they do not recommend tigecycline to be used for pneumonia. Apparently, most of the people writing this document did not work in ICU, so probably I will have to accept that from them, but we're not accepting that in our ICU. The problem was that the breakpoint for tigecycline, when it comes to pneumonia, was not identified. So the standard dosing of a tigecycline of 100 milligram followed by 50 BD, it doesn't work in pneumonia. But if it is the only antibiotic you will have it, or an MDR Acinetobacter, you will use it, you will not leave the patient to go. If that tigecycline was there for a complicated intra-abdominal infection, we know for sure that tigecycline penetrates the tissue very well. And if you give it in 100 milligram BD, probably it will work with the pneumonia as well.
We have a question, last question here.
Yeah, thank you very much, Dr. Ashraf. My name is Dr. Shirazi. I'm working as a intensive therapy hospital Abu Dhabi. I think we have all of us to really look after the pharmacodynamic and from the colistin. Colistin is not going to treat any MDR back. No way, because it's not working. It's working only with the wall. It will allow other carbapenem to enter that one, or beta-lactam, whatever, to enter and to kill the back. So there is no recommendation at all. And forget it. We use colistin alone. You have to combine with other drugs, or carbapenem, or something else, beta-lactam, whatever is there, or even aminoglycoside. So this is the general concept. You have really to start with it, because this is effective, not other things. Please.
Yeah, the colistin, I mentioned that already. Using colistin as a monotherapy is not a good practice. It will not help you in treating MDR organism. The problem is when it is an MDR pseudomonas and you have a very little chance of treating it with an aminoglycoside or a carbapenem, you still will use a cell wall antibiotic from the beta-lactam group, which is the carbapenem at a high dose, plus the colistin. If it was an Acinetobacter, then adding tigecycline will become a good choice. But definitely, colistin alone is not a good choice to treat MDR pseudomonas.
We have time for last 1 minute question. Before anybody has a question? Yes, Doctor. So this is you, Doctor. Yes, yes. Yeah. You have 30 seconds and 30-second answer. Mike to you. The question is over. Myself.
It's regarding levofloxacin. The recommended dose for levofloxacin 750.
Yeah, that's it.
Yeah, but what we have
500 milligram dose.
it does not exist anymore. Yeah, forget it. So I mean, in UAE, I don't know if in USA they have the 750. We have here only 500. You will have to lose 250 and throw them somewhere, but the 500 milligram dose does not exist anymore.
Thank you, Dr. Ashraf. Thank you very much for the break. You should be here by 12 o'clock. The next session will start at 12. You come late, lunch late, evening session late, and then we finish late. So please come and come here 12 sharp. We in the room, come 5 minutes before 12. Finish your coffee while you're in the room.
This next one, severity of illness. You can see that the Am I still there? Can you still hear me? Yes. You good?
Yes, Professor.
My hospital just had a quick power outage. I apologize for that. Okay, if you can still hear me, I'll keep going. If you can't hear me, someone stand up and wave. Okay, so the Andes paper clearly showed that across the different quartiles of Apache 2 score, removing of the central line to a new site, new stick, after correcting for other differences in severity of illness and stuff, really was associated with lower mortality. So every guideline currently recommends that whenever possible, please change, when you have a Candida bloodstream infection, change the central line to a new site. And I think that's important. This is again seen in a Spanish study that looked at the combination of early appropriate therapy and catheter removal. It was a prospective observational study as opposed to these retrospective studies. It clearly showed that if you end up getting earlier appropriate therapy while independently not statistically significant and changing your central line to a new site, new stick, when you combine both of those, there was an overall improvement in survival. What also came out of this analysis in a different paper, they had a very high rate of Candida parasilosis. And we know that the Echinidea candidates as a class have a higher MIC, generally in the 2 range of parasilosis. There's many microbiological reasons for that, but they noted that if someone was initially started on the Echinidea candidate, when they eventually moved Candida parasilosis, there wasn't a worse outcome. We still routinely would switch that patient to fluconazole based on effectiveness and cost effectiveness, but there wasn't harm or a downside to starting patients with Candida parasilosis on the Echinidea candidate. For parasilosis, the Echinidea candidates are not our drug of choice. Fluconazole still appears to be the drug of choice, at least here in the United States. When you look at the 2016 guidelines, there was a large shift in what their recommendations were. Here was the first time in the IDSA guidelines that a Echinidea candidate was recommended as initial therapy. The European guidelines, which I'll show you from 4 years earlier, were in 2012 actually came out and suggested Echinidea candidate as initial therapy. They did say fluconazole was an alternative, either intravenously or oral, but they recommended a reasonably high loading dose and then more reasonable 6 milligrams per kilogram. But this was in a subset of patients who were not critically ill and were unlikely to have fluconazole resistance. They clearly recommended testing for azole susceptibilities, but again, this is not always available in a lot of different hospitals, not only in the Middle East, but my colleagues in Central and South America, and some of even the smaller hospitals in the United States. Susceptibility testing for Candida species is not universally available. They do recognize that the Echinidea candidates are a more expensive class than fluconazole and the other azoles, and so therefore they recommend switching to fluconazole or voriconazole if it's a more likely resistant pathogen at 5 to 7 days when patients have clinically responded. And again, I'll show you the Joe Vasquez study that we also were a part of that clearly supports this use of early switch in somewhere in the 5 to 7 day range. A way of bringing antibiotic or antimicrobial stewardship to our fungal patients. They do recognize that there's a higher MIC in Candida glabrata, and therefore if you're going to use fluconazole, you should have susceptibility and actually probably dose at a higher dose than other Candida species. Voriconazole is another drug that we use here a lot. We have reserved the pollines, and so the guidelines recommend that as well, to really unique populations. The lipid complex are much more expensive and still have significant toxicities, and that they clearly recommend removing the catheter. This is actually fairly consistent with the European guidelines that came out in 2012 and other guidelines that have come out throughout the globe since the publication of all the different studies, including the Ames paper. They recommend treatment change at 10 days from IV to PO, but clearly there's data that suggests that if your patient's clinically responding, then you can go ahead and switch earlier. We tend to try to switch somewhere between day 5 and day 7 in about 2/3 of our patients with Candida bloodstream infections in my medical center. There are 3 studies that actually looked at, these are all Candida bloodstream infections, looking at the azoles compared to the azoles such as fluconazole or voriconazole compared to standard deoxycholic amphotericin. These are some of the earlier studies, the 2 mycosis study group studies, which were the REX 1 and 2. The first study looked at fluconazole versus amphotericin, and interestingly enough, there was a suggestion that you had a better cure or improvement rate with amphotericin, but on flipping the other way, there was a slightly higher mortality, although neither of these numbers were statistically significant. We then looked at a combination study with fluconazole with or without amphotericin, and again, no difference in mortality. And the voriconazole versus amphotericin with oral switch with fluconazole when appropriate also showed similar outcomes as well. Again, these were all in Candida bloodstream infections. I'm going to spend one additional slide on the voriconazole treatment. It worked equally well to amphotericin. We tend to use voriconazole now more in step-down therapy, especially in our Candida glabrata, some of the other non-albicans. When patients are clinically responding, clear their bloodstream infections, we clearly switch to voriconazole in the glabrata population and some of the Cruzii and other populations as well. It is an excellent choice for the more resistant Candida bloodstream infections that are resistant to fluconazole. There are 4 studies out there in randomized clinical trials that look at a kind of candid versus the amphotericin or fluconazole. Only one of them, the Rivoli trial, for which I was an investigator and an author, looked at indiclofundin versus fluconazole. Once again, there are non-significant differences in the top 3 studies in overall outcome. The more Duarte study studied cathepafungin versus amphotericin. The Coos study showed mycophenolate versus liposomal amphotericin. The most recent study looked at 2 different, with Pete Pappas, looked at 2 different doses of mycophenolate versus cathepafungin. This led us to use 100 milligrams of mycophenolate because there's equivalency between 100 and 150. The only study that went head-to-head with an echinocandin candidate versus fluconazole was the Rivoli trial. And it was also the only study to show a significant difference in the overall primary endpoint, which was clinical cured or improved, and a suggestion towards improvement in survival. The p-value was not significant on survival. The p-value was 0.1, so at best a trend, but it's important to note this difference was not statistically significant. We'll go through that study more in detail. The Andes paper, which I showed you the central line data on earlier, was able to get all of patient-level data from the pharmaceutical companies that sponsored these trials and put it into a database, and therefore had 1,950 patients from the 7 different invasive candidiasis trials. While this is not a study in itself, it's a reanalysis of these 7 different studies. And they looked at day 30 mortality and said the overall mortality was in that 30-31% range, which we've seen. Factors that impacted survival, okay, was the number 1, your drug that you were randomized to, with the lowest mortality being 27% for the echinocandin candidates, and then the polines and the azoles tending to have a mortality of 35 or 36%. Factors that were associated with a higher mortality, increasing age, higher Apache 2 score, use of the immunosuppressive therapy, and in this analysis, these species of Candida tropicalis. The 2 predictors that for decreased mortality or improved survival was taking out the central catheter and being randomized to an echinocandin therapy. So again, once again, it's very clear that it clearly suggested that the initial choice of an echinocandin was associated with improved survival. And I think that's why the guidelines, both in 2016 and in 2012, recommended echinocandin for all therapy, for his initial therapy. This is not the only study that suggests this. 3 years ago, a study out of Brazil, my colleague Dr. Colombo, actually looked at nearly 1,400 episodes of Candida bloodstream infections, nearly half of them occurring in the intensive period in Brazil. And they looked at factors that impacted 30-day mortality. And very similar to the Andes study, which I just showed you, that getting immunosuppressive therapy such as corticosteroids, being earlier in the group, we've actually improved our therapy over time, higher Apache 2 score, and age, all have an odds ratio greater than 1, meaning associated with a higher mortality. The only factor that was associated with an odds ratio less than 1, improved survival, was the treatment with an echinocandin first. Once again, supporting the guidelines in the treatment of using echinocandin as initial therapy. As I mentioned, we do spend more time on the Rivoli trial. I think this is a very important trial in the fact that it's the only prospective, randomized, multi-center blinded study that compared echinocandin, in this case a digital fungin, versus fluconazole. Fluconazole was given at a reasonable dose at 800 milligrams on day 1 and then followed by 400 milligrams thereafter. Digital fungin is given with a loading dose of 200 milligrams on day 1 and then 100 milligrams thereafter. Because this was a registry trial, you needed to receive at least 10 days of initial therapy so that regulatory bodies such as the Food and Drug Administration could say that any differences in outcome were related to the therapy and not just to chance or background noise. So everyone got at least 10 days of IV therapy, 10 days of therapy, then could be switched after day 10. Patients were stratified based on their Apache 2 score and whether or not they're neutropenic. Very few neutropenia patients got enrolled in this study because fluconazole does not have aspergillus coverage, and therefore you're reluctant to enroll someone who may have aspergillus. When you look at the primary endpoint was clinical success defined as improving your signs and symptoms and clearing your site of infection at the end of primary therapy. That was the primary endpoint. And you see approximately a 14% difference in favoring a digital fungin over fluconazole. Now this was a non-inferiority trial, so for those of you who are familiar with those would understand that to be able to market the drug, digital fungin had to be found non-inferior to fluconazole. So that meant this confidence interval could not touch the line of this line of -20, which was the limit set there. Now, they had planned to do multiple analysis, and if it met non-inferiority, they would then look for superiority or improved efficacy. And to do that, they actually paid a statistical penalty. These are not actually 95% confidence intervals, they're 98.3. Figure out with the statistician where that number came from. But you can see that the average at different time points all line up in that 12 to 14% difference in clinical response. In the 3 top curves, it all did not touch the line of equality and therefore were statistically significant. You lost numbers of patients to follow up, so at the 6 weeks follow-up, it did not quite meet statistical significance, but there's an overall trend of about 12 to 14% at the end of IV therapy, at the end of all therapy, at 2 weeks follow-up, and a trend there as well. Now, as one of the investigators and one of the people who helped start the study, I was not surprised at these findings. But when we looked deeper, I was surprised at what drove this study. And that you'll see on this slide here. I expected a difference in the non-albumous arms where there was resistance. And while it wasn't statistically significant, you did see an 11% overall clinical response rate in the group that got a digital fungin over fluconazole. But what drove this study, and we have a second paper on this, was actually the Candida albums arm. Here you saw a 19% difference in clinical response, independently was statistically significant, but drove our study. In fact, it showed that overall it was a better overall clinical response. And I want to be very clear here, this is not statistically significant, but if you look at the Kaplan-Meier curves, you see a relatively early separation in about 1 week. When you follow it out to 60 days, there was actually numerically 8% difference in survival, favoring a digital fungin, 31 versus 23%. Again, the p-value on the Kaplan-Meier curve here is 0.1, it's not significant. But I think consistent with the primary endpoint, which was significant, was better overall clinical response, you see a suggestion, although not statistically significant, improvement in survival, favoring a echinocandin and digital fungin over fluconazole. And that is consistent with what the Andes paper and the Colombo paper showed, that being randomized to echinocandin showed a better overall outcome. What also was surprising was the fact that we saw many less side effects and discontinuation of drugs in the echinocandin arm. We've always felt that fluconazole was one of the better tolerated, safer drugs to give. Now, that's easy when you're comparing it to amphotericin. But in the Rivoli paper, you saw fewer patients discontinue the drug either for getting worse clinically or having an adverse effect than fluconazole, essentially about half as many side effects. We'll talk about the side effect profile in my next talk. We did a second analysis just on the Candida albicans bloodstream infection, and I want to point out this was not a resistance problem. There were only a couple of patients who had any species that was relatively resistant or dose-dependent to fluconazole. The majority of them had well less than an MIC of 2, so the differences were not related to resistance. And might be due to static versus cytal. This is looking at the Candida albicans subset. You saw a much faster clearance of the bloodstream infections in the group that got indiclofungin than fluconazole, possibly speaking to either biofilm penetration or cytal versus static activity. We also looked at the guidelines that came out in 2012 from the IDSA recommended that you treat the more severe population, your critically ill population with a kind of cannon. We tried to look at that as well. We predefined the definition of critically ill by having a higher than average Apache 2 score, severe sepsis with at least one organ dysfunction, or getting the Candida infection to the ICU at baseline, in which you can see here that you saw on average, although not all of it statistically significant, you see that there was a better overall clinical response, and there was a trend towards improvement in survival early. The p-value here was 0.07, not statistically significant. This mirrors an open-label study in the intensive care unit where you see very good clinical responses across the board at the different time points, as well as in basically a European study, open-label, looking at a kind of cannon and indiclofungin in patients who were critically ill. We also wanted to try to do cost-effective analysis, which can be very difficult, especially when we're retrospectively looking at data. The take-home message in this slide, it appeared that indiclofungin appeared to be cost-effective in the group that was in the intensive care unit patient population, and therefore on average decreased the number of days, although there's very large standard deviations, but on average looked to be cost-effective in your more critically ill patient population. I think this is the last slide for this talk, and I think it speaks to our antibiotic stewardship and cost-effective presentation. This is an open-label phase 4 study looking at a kind of cannon and indiclofungin, and if your patient population had clinically responded, so they were afebrile, able to tolerate oral medications, it cleared their bloodstream infection, you could then switch to fluconazole. You're able to do this in about 40% of your patients. You cut the duration of therapy with the more expensive kind of cannon, and it was very safe to do whether you switch to fluconazole or voriconazole. So again, I'm a believer in early aggressive therapy with a kind of cannon. We actually have different kind of cannons on formula at different hospitals. We'll talk about some of the differences of those in my next talk. But you have a very good success rate. Ease of switching over in about 2/3 of your patients over to oral therapy, even in the intensive care unit, and therefore you can do cost-effective medicine. And at this time, I'd like to stop my talk on my first lecture and open it up to any questions from the audience.
Thank you very much. We have time for a question, please. And we hope the next presentation will take 15 to 20 minutes only because we are late in the time of the program. Any questions here, actually? I have one question myself. I'm here, I'm Dr. Hussein. So when we talk about septic shock and serious infection, we always say 1 hour of delayed antibiotic, it counts. Each hour is 7% mortality. So we always say in the guideline, give antibiotic within the first 1 hour. When it comes to fungal infection, the slide that you showed us, and we see that frequently, it says what matters is 12 hours or less or more. So it's okay, 1 hour, 2 hour, 3 days. A little bit of discrepancy, especially knowing that, which you showed in your slide, that the mortality of candidemia is even higher than mortality of serious bacterial infection. Is that question clear?
Yes. A lot of the septic shock, bacterial septic shock data actually comes from retrospective studies like Dr. Kumar, and clearly suggests that every hour you delay appropriate antibiotics, you have a worse outcome. The prospective data on this is not as clear, but I think all of us in critical care and in your audience would agree early appropriate therapy is there. The problem with trying to do this for Canada is that it is a relatively infrequent cause of septic shock. It looks identical to bacterial infections, but it's not a frequent cause. And then you're now getting to the cost-benefit ratio of starting it. I think we need a better diagnostic test, whether you want to use the T2 Canada system, which costs, at least in the United States, nearly $250 to run, or some other marker. But until we have a better early marker, it's very difficult to decide who to treat, because you are going to treat many patients up to with an antifungal agent who don't need it, may drive resistance. It's something we struggle with every day in the intensive care unit. We have, as I showed you, half my patients are in there over 2 weeks. They have a lot of risk factors for invasive canal infections. When they decompensate and there's not an obvious bacterial infection, we often will try in a kind of candidate, but we have a very strict rule. If you do not grow candida in the bloodstream at day 3, we're stopping it. So we still use empiric therapy despite the negative studies, because when they're in septic shock, you don't have the ability to delay therapy. But we're very strict on stopping it at day 3 if there's not documented a candida infection. It's a way of trying to do cost-effective medicine. I just wish we could find out more clearly who's at higher risk. And one of the papers that we're writing out of the VA database, unfortunately, mirror the mycofungin study, that multiple site colonization and/or clinical risk factors is not a good enough discriminator to determine who has candida bloodstream infections, and therefore may not be a good clinical utility and cost-effective use of antifungal therapy in that group. Very difficult question, hard to treat, and hard to bring into the clinical arena because these patients are sick and you don't want to delay therapy.
Thank you very much. So we'll proceed with the next presentation. That will speak about the group of echinocandids, and we'll see what the data says about it. I hope that will take 15 to 20 minutes maximum.
Yes.
Please.
This is a shorter lecture. We're going to talk about the echinocanid candid class. I think I should be able to finish in the 15 to 20 minute time allocation. So the echinocanid as a class end up having a very similar structure, but there are differences. And probably when you look at, you have a very similar ring, but it's these lipophilic side chains that actually make the uniqueness of the candida, the kind of candidates in treating candida, both in the pharmacokinetics, susceptibilities, and how these drugs are metabolized. That's probably one of the bigger differences in the drugs, is how they're metabolized and therefore their potential side effects moving forward. When you look at, this is in the United States, USA approval and when they came out, all 3 of the echinid candidates end up having an indication for treating candidemia and invasive candidiasis. The dose for caspofungin is a 70 milligram load, 500 milligrams a day. The dose for mycofungin is 100 milligrams without a loading dose. The dose of injected is 200 milligrams on a loading dose, 100 milligrams a day. They all came out, the earliest one was caspofungin. But there are some differences in the FDA approval. All 3 have esophageal candidiasis, and I would not recommend an echinid candid for treating this. We have better oral therapies such as voriconazole and fluconazole when it's fluconazole susceptible. But there are some other differences. We also need to know that while they may be approved in the United States, not all of these are approved in either the Africa region or the Middle East, and therefore, such as prophylaxis for mycofungin and esophageal candidiasis are not currently indicated in this arena. I think this is important to know that there are differences as well, and also knowing what's different in different regions throughout the world. You saw the slide earlier. Generally, a kind of candida class are very effective against the candida species, as well as having activity against Aspergillus. It's important to note that they do not work against Mucor or Rhizopus or Fusarium, and have no histoplasmosis or other therapy. So they are really considered a predominantly candida treatment class with activity and possibly combination therapy for Aspergillus. We mentioned some of the differences in the pharmacokinetics, and I'm not a pharmacist, but these are all pretty much manageable, especially since we round in our intensive care unit with a clinical pharmacist. It's also important because of their size and some of the other characteristics. There is generally not good penetration in the urinary tract, less than CSF and vitreous, although one of the things that was encouraging in the large randomized studies, you did not see a high rate of candida endophthalmitis. Actually, it was less than 1 or 2%. I think this is more for more effective earlier therapy and earlier recognition. It's important to note that these drugs as a class not only have predominantly a concentration-dependent killing, so for the most part we're familiar with that with some of our antibiotics, it's area under the curve above the MIC, but also there appears to be a long post-delivery antifungal effect, so these drugs seem to work well and with a relatively long half-life and then secondary effects as well. There are differences when you look at the different half-lives, with the longest half-life being with the nidulafungin, on average slightly over 26 hours, where micafungin is somewhere in the 15-hour range, and caspofungin somewhere around 10 hours. What this means clinically, I really don't know. And nidulafungin has really only been studied on a once-a-day dosing. I've been asked in the past, because of this half-life, could you dose it nidulafungin every other day to decrease its cost? The answer is I wouldn't do that. It's not been studied in that population, and all the studies tend to use everyday dosing with nidulafungin, and that's what we use clinically. We also have a larger volume of distribution between nidulafungin, micafungin, and caspofungin. This might play a role if you have a deep tissue infection. I'll show you some tissue concentrations that get, at least in rats, in different kind of candids, which may be important as well. Again, in this slide, you see that probably the highest tissue concentration, again, is the area of the curve, again, in a rat model, because it's very hard to do in humans. The best tissue penetration compared to the plasma tends to be with the nidulafungin, followed by caspofungin, and then micafungin. Again, how this plays out clinically is not as clear because the number of patients with deep tissue infections are relatively small in the studies, but I'll show you in a slide that they tend to work, as a class, tend to work well in these invasive candidiasis tissue infections. So this is the slide I'm talking about. This looks at the 4 different randomized trials, the Rivoli trial, the Moore-Duarte study, the Coos trial, and the Papin study that we talked about earlier. If you look at this non-bloodstream infection line, you can see that the rate of non-bloodstream infections, so therefore invasive candidiasis infections, varied from a low of just under 9% to a high of 21%. So again, they had relatively low percentages in the group. Again, most of our data is on bloodstream infections. When you group all the echinidins together, you end up with 146 patients in these 4 clinical trials. The clinical success rate was 120, which comes out to about 82%. And the other agents, depending on which study you're in, ended up having about 67%. So it appears that the echinid candidates, while there's not a lot of clinical data on the invasive candidiasis and deep tissue infections, seem to work pretty darn well across the board. When you look at, this is one of the earlier susceptibility studies that was published. It was published in 2003. It looked at 2,000 bloodstream infections. You could see that as a class, the echinid candidates ended up having very low MICs, lower than both voriconazole and fluconazole on average. The one major difference was Candida parapsilosis. where you ended up seeing across the board an MIC of 2. Again, I mentioned the Spanish study did not seem to indicate that initial therapy with an echinocandin candidate led to worse outcomes. There were some breakthrough infections in the more Duarte study with a resistance parasolosis to the caspofungin, but on average it seems to work fairly well. Our drug of choice still is for parasolosis, once it's identified, susceptibilities are known, is fluconazole, at least in the United States and in my institution. This is another study looking at it. You're not supposed to be able to read it, but if you get a sense, this study is published 3 or 4 years later, the MICs seem to be shifting off to the right here, in several different ones, both with parasolosis as well as some of the other non-albumin species, possibly suggesting higher MICs and therefore worse clinical outcomes. A more recent Greece study that came out still shows very good susceptibilities. Even in Greece, Candida parasolosis for these, when you compare it to some of the newer azoles, posaconazole and voriconazole, but parasolosis still had the overall MICs of 2 for the kind of candidate class MIC90s. Fluconazole, at least in Greece, was getting a little bit worse for there. And the most recent study that I showed was very concerning. This looked at more resistance, where both in the wards and in the intensive care unit, you're seeing some resistance in Candida burrata, less than 2% on average, closer to 6% for fluconazole and voriconazole, and then some breakthrough for caspofungin and Candida krusei. One of the things I believe, both for bacteria and fungus, you have to have antibiotic stewardship. And if you just use one class of antifungal, you will see resistance develop. This is very important. So while I support the guidelines recommendation for an initial echinocandin candidate for treatment based on its efficacy and side effect profile, if you know the antifungal species is susceptible to another agent, or they've clinically improved and you can change your therapy to an oral agent, then I think you should do that, not overuse just one class of antifungal, or else you'll see a worsening resistance problem. We've seen this with our bacterial infections, and we're starting to see it creep into some of our antifungal therapies. I do believe that the echinocandins play a role in the treatment of Aspergillus. As you can see here on this slide, despite the species, there tend to be very low MICs. MIC90s for Aspergillus for all 3 of the echinocandins. There was the more recent Karen Marsh study that just came out in the Annals of Internal Medicine approximately 2 years ago that looked at high-risk patients with either stem cell transplant or hematologic malignancies who met the mycosis study group definition of proven or probable invasive Aspergillus. So in your heart of hearts, you believe they have Aspergillus, and then we're randomized either to voriconazole with injected or voriconazole with monotherapy, and it was clearly suggested that there was a better overall outcome. I'm going to be careful here. It was not statistically significant, but there was an 8% numerical difference in survival that failed to meet statistical significance. The p-value here was approximately 0.1, but across the populations, you saw that it appeared to be effective.
تقريبا كان جاي في كل حته في الفندق الاول. coba. Hal yang ada.
السلام عليكم.
عملت طب كويس